Good morning, everyone. So today I have a case. This is a case of thoracogastric airway fistula presented a few months after esophagectomy. So we will discuss about this case and do a literature review and plan how further we can manage this case and these types of cases that infrequently present after esophagectomy. So my patient is a 50-year-old male from Makwanpur. He's a reformed smoker. There was no issue of comorbidities, and he presented 1 year back with the issue of progressive dysphagia and weight loss. On presentation, it was a grade 3 dysphagia. So initial evaluation at that time revealed an esophageal ulceral proliferative growth on endoscopy and imaging. On endoscopy, the growth was from 27 to 35 centimeters from the upper incisors. So this was mid-esophageal tumor. Biopsy was taken, which revealed squamous cell carcinoma. CT scan of that time, I don't have the films, but it revealed circumferential wall thickening involving the esophagus with marked luminal narrowing. And there were mildly enlarged and enhancing discrete periesophageal lymph nodes. So, with these investigations, he was diagnosed as a case of locally advanced esophageal carcinoma and was advised for neoadjuvant treatment. Uh, because of the issue with radiation therapy in our center, the patient, after discussion, underwent a plot course perioperative chemotherapy regimen, and he received 4 cycles of neoadjuvant plot course. One important issue during the chemotherapy was that the patient developed bilateral lower limb arterial thrombosis after the second cycle of neoadjuvant chemotherapy, and he was managed in our center with thrombolytics and anticoagulants. So following NSCT, the patient recovered from the arterial ischemia, and the patient completed his neoadjuvant protocol and then was evaluated for surgery. Post-surgery, the CT scan and the endoscopy revealed essentially no regression of tumors. So this is the endoscopy finding. There was a growth in the mid-esophagus. And here, this is after chemotherapy. And although I don't have the pre-chemotherapy images, but it was the findings were similar, and we can see the growth in the mid-esophagus, and we can see it is averting the carina and both the right and left main bronchi with marked luminal narrowing that can be seen. So with this, the patient was advised for surgery, and he underwent surgery on Bhadra 16th. He underwent the VATS 3 inches and McEwen's esophagectomy with gastric pull-up as a conduit, and intraoperatively the findings were a hard mass at the mid-esophagus around 5-6 centimeter in length, and it was involving all the layers, and it was densely adherent to the lower trachea, the right and left main bronchi, and right lung. And enlarged lymph nodes were noted at levels 107, 108, 109, and 110, and no distant metastasis in the right pleura and the abdomen were noted. And the histopathology of the surgery revealed a well-differentiated squamous cell carcinoma of grade G1 invading the adventitia, and there were the proximal and distal dissection margins were negative, but the radial margin revealed less than 1 mm distance from the tumor. And in case of the renal lymph nodes, of the 7 nodes that were identified by the pathologist, 1 came out to be positive. So this was a YP T3N1 disease. So in the immediate post-operative period, the patient developed, initially he was started with the oral fluids, and the patient tolerated in the early days, but later on the patient developed partial anastomotic dehiscence, for which was managed conservatively. Internal feeding was done via feeding genostomy, and the patient was kept nil per oral. And the patient was discharged in this condition with JT feeding and advised for NPO. And after 6 weeks of surgery, the patient was still under feeding genostomy, and he was evaluated with an endoscopy, which revealed a leakage at the anastomotic site, and there was a stricture at the same site. Bronchoscopy was also done at the time. It revealed a growth at left main bronchus with near complete obstruction, but there was no signs of any fistulation. So because of these findings, the patient was continued in feeding genostomy and was advised for continuing the adjuvant chemotherapy. His performance status was normal because he had continued the interval feeding with the JT. So he received 4 cycles of adjuvant flot also, and the last cycle of chemotherapy was on MAG of 13. Following the final chemotherapy, he was again evaluated with a CT scan, which revealed a growth in the post-surgical bed around 5 into 5 into 3 centimeter, irregular infiltrative enhancing mass in the mid part of the pull-up stomach, which had a poor fat plane with bilateral main stem bronchi. So this is the post-chemotherapy picture. You can see the tumor has grown in size, and it is compressing both the main bronchi, and there is the tumor, and it is also compressing the stomach. So we can see there is almost anastomotic stricture. There is complete stricture, and the patient would not be able to feed orally. So again, upper GI endoscopy was planned, and it revealed a complete stricture at the anastomotic site, and scope could not be negotiated beyond. Bronchoscopy was also done with the view that there was some growth prior also. So it revealed a polypoidal growth with inflamed mucosa in the proximal left main bronchus, just distal to the main carina. So after discussion with the medical oncologist, radiation oncologist, and the surgical team, the patient was planned for palliative EBRT, and this was started in Phagum, as we thought that the patient will not have any advantage with any further surgery. So he received. He was planned for 28 cycles of radiation therapy, but because of the poor condition, he could only receive 20 fractions. So now the patient has presented to us. He is under feeding genostomy. There is no oral intake, and he was unable to complete the full RT dose. And he has presented with cough and shortness of breath around 2 weeks back. We did the upper GI endoscopy, which again revealed the anastomotic stricture, and bronchoscopy was done, which revealed 2 large fistulas opening in both the main bronchi at the level of the carina, the larger of which was in the left main bronchus. So this we can see in this video. This is the video of the bronchoscopy. So has been done today morning only, and so this is one fistula at the junction between the right and left main bronchus. So this is the right main bronchus, and here you can see this is the fistula. So it is at the junction between the right main bronchus and the carina. This is the smaller fistula. This is the distal right main bronchus, and the bronchus intermedius is normal. And then this is the fistula in the left main bronchus at the junction between the carina and the left main bronchus. This one is the larger, and I could even pass the scope through the fistula and could visualize the gastric epithelium. Distal to it is normal. So the patient has symptoms of cough and pneumonia. Because of this, we can see this is the gastric epithelium. There doesn't seem to be any gross mass, but there are flakes in the fistula site, and small ulcerations could be malignant. Biopsy was not taken from the site. So here is the right fistula, and this is the left medullary fistula. So this is our case. The patient is currently in stable condition. He has no chest issues at the moment, and he was treated with IV antibiotics and close monitoring in the SDU, and the patient has been shifted to the ward. And now we have to discuss how to further manage this patient. So what could be the further management in this patient? So first, I'd like to do a small literature review on the thoracogastric airway fistula. These are uncommon complications after esophagectomy, with an incidence of 0.3 to 1.5% of all esophagectomies. And these are life-threatening complications, and the fistulas, they may be located in any location of the tracheobronchial tree, including the trachea, carina, the main bronchi, the lower lobe bronchi, and even further distally. And they may be either early fistulas presenting in the immediate post-operative period. This is because of either ischemia of the gastric conduit or anastomotic lesions that happens in the immediate postoperative period, or intraoperative injury to the tracheobronchial tube. And there may be late fistulas which present after the patient has healed, and these are because of the tumor recurrences or ischemia of the gastric conduit. So our case is a case of delayed thoracogastric airway fistula. Usually the presentation is coughing on swallowing, recurrent aspiration or pneumonia, fever, and unexplained sepsis in a patient who had previously undergone esophagectomy, and they usually present weeks to months and even years after surgery. So what are the risk factors? So the most important risk factor is anastomotic leakage, a history of prior radiation or radiation in the cases who have recurrence, and extensive surgery including lymphadenectomy is also a risk factor, and injury to the airway or conduit staple line during the surgery may also present as a late or early fistula. So there are no guidelines on the management of these fistulas, as these are rare complications. There are only case reports and case series. So there are essentially three paradigms that we can undergo for management. The first is the conservative treatment. The second is non-surgical procedures such as endoscopic management. And finally, the most radical is the surgical repair. So we have to plan according to the patient's condition, the disease status, how further to manage the patient according to these three types of management protocols. So coming to conservative management, the approach includes nil per oral, IV antibiotics, gastric decompression and or drainage of collections if there are any, and nutritional support in the form of either feeding geniculoscopy or TPS. And this is appropriate for hemodynamically stable patients with small contained fistula and minimal symptoms. And this is usually not favored, and because in cases of large fistulas or recurrences, healing of the fistula will not occur with conservative management. But if the patient is advanced tumor with poor long-term survival, then this can be also used, or in cases of very small fistulas with minimal symptoms, this approach can be used. So this is a case report of gastrotracheal fistula following esophageal cancer, and here the fistula was managed with the conservative treatment. So there are case reports of patients being managed with conservative treatment by IV antibiotics and drainage of the collections. And it can be, they have noted that the fistula was healed after 48 days of conservative management. So the other approach is the endoscopic management, and these include various options, including covered stents over the scope clips, the endoscopic sealants in the endobronchial or atrial occluders, and also endoscopic vacuum therapy. And the covered stents may either be a covered gastric GI stent or a covered tracheal bronchial stent, or in some cases, if required, a combined gastric and tracheal bronchial stent can also be used. So there are various case reports and case series on this topic. So this is a case report of a bronchogastric fistula which was successfully treated with the insertion of a covered bronchial stent. And there are other case reports where a self-expanding esophageal metallic stent was also used to allow the exclusion of the fistula. And this also relate to the healing of the fistula. In this case, actually the patient also received endoscopic glue treatment to cover the defect, followed by a metallic clip, and then the stent was applied. But there are other case reports that where only use of esophageal metallic stent have led to resolution of the fistula. One issue with the metallic stent is that there can be migration of the stent, or it can further erode and increase the size of the fistula. And there is the issue that the leakage may occur from the side walls of the stent, leading to continuation of the fistula. Then there are other case reports which reveal that where double stent was used for malignant gastroesophageal airway fistulas, and this was a case series where 11 patients were treated using the double stents. The Dumont stent for the airway and the covered metallic stent for the esophagus. So these are the esophageal, the tracheal and the tracheobronchial stents, and they have such kind of outpouchings for support to prevent slippage or movement of the stents. And this is the Y type of stent where both the right and left main bronchus are also stented. So here we can see this is the trachea, this is the right main bronchus, the left main bronchus, and the stent can be covered over the tumor or the fistula using such a device. And other approaches that have been used are the over-the-scope clip applications to close the gastrobronchial fistula. Obviously, a very large fistula cannot be healed with this type of approach, and also the margins of the fistula should be healthy in such cases. This is also another case report of over the scope clipping, and here the treating doctors, they use the argon plasma coagulation first to treat all the surrounding unhealthy mucosa by the argon plasma coagulation, followed by application of the over the scope clips. Then there is a single case report of closure of the esophagus and tracheal fistula using the cardiac septal occluder. This is an interesting case report where the patient had undergone multiple endoscopic approaches and also surgery with myocutaneous flap, but the fistula did not heal. Finally, with the help of an interventional cardiologist, they used this atrial septal occluder device, and following the application of this device, the fistula was healed. Then another approach is the endoluminal wound vacuum therapy, and here this was a case report where a patient with the thoracic fistula was treated with the help of the endoluminal vacuum therapy, and the fistula healed after 9 days of therapy. So this is another approach that could be used for management of these types of complicated fistulas. So there are many case reports of these types of management also. So this was a case report where a surgical approach using the transection of fistula was done and primary closure was done with the intercostal muscle flap interposition. Then there are other case reports where a reversed pericardial patch, which was reinforced with the intercostal muscle flap, was also used in this other case report. So in this approach, initially this is the fistula and at the distal main trachea, and the surgeons, they took a pericardial flap which was pedicle. They covered it over the fistula to repair the membranous portion of the trachea. Following this, pedicle intercostal flap was taken and covered over the patch repair, and this led to healing of the fistula. And there are other case reports. This is a case report where the surgery was done with dismantling of the fistula and primary closure of the defect, which was then covered by the intercostal muscle and latissimus dorsi muscle flap. So again, this is a case of a staged pedicle myocutaneous flap for fistula. So in this approach, the latissimus dorsi was harvested with the a portion of the skin and subcutaneous tissue, and then it was covered over the fistula's opening after dismantling the fistula with the skin sutured to the inner layer of the membranous portion of the trachea. So this is the approach. They took the flap from here. The latissimus dorsi was harvested. This is we can see the pedicle latissimus dorsi flap with the skin. Then after dismantling the fistula, this is the final bronchoscopy picture where the flap has been kept over the fistula's opening and the patient healed. Then there are other case reports where the use of allodome patch biological mesh was used, which was reinforced with the intercostal muscle flap. So here we can see this is the biological mesh through the bronchoscopy, and over this the intercostal muscle patch was used to finally cover the defect. So there are various approaches that we can use for management of such fistulas. And so what are the outcomes of surgery? The direct surgical repair has high immediate success rate when performed by the experienced teams, but also carries substantial morbidity. And again, the complications can include leak even after reanastomosis, mediastinal infections, airway stenosis, and a donor site morbidity. And the reported mortality after such surgeries is very significant, with up to 50% of mortalities. Thus, the surgical repair is generally reserved for patients who are fit enough to tolerate this procedure with no other options of treatment. And although there is a high morbidity and mortality, but patients who recover from the surgery have good outcomes. So with this, I'd like to complete my literature review, and I'd like to invite discussion on how we could manage further for our patient in our hospital.
Thank you, Dr. Ashish. So, few questions where I have got few queries regarding this. This is indeed a very challenging case. First, you made the diagnosis of the esophageal cancer, esophageal thoracogastric. What was the location of the tumor? You should write completely. I think this is the medicine.
Yes, sir. Right. Yes, sir.
Second case question: what was the stage, clinical stage before starting with the new surgery?
Because starting it was a locally advanced
N plus disease, right? So the chemotherapy regime that was chosen was the 4-4 in a context of neoadjuvant chemotherapy. Do you think the 4-4 regime is good?
So initially we are advised for neoadjuvant chemoradiation, but because of delays in radiation therapy, the patient it was discussed that he would benefit with the neoadjuvant chemotherapy, and so in literature it has been shown that the DCF regimen is good for esophageal squamous cell carcinomas. Although the FLOT4 regimen has not been evaluated for the squamous cell carcinomas, but I think the medical oncologists, in our center, they think that it is of similar potency.
So I think we should believe in the evidences. So without evidence, I think it would have been better if we had started with either the cisplatin 5-FU or DCF receptor. That is the standard of care in the context of squamous cell CA. The other regime that we could have used is the paclitaxel carboplatin. Not with the radiation therapy. That is the routine standard practice in Tata Neuro Hospital, and they have got a good result only with the 3 cycles of neoadjuvant paclitaxel carboplatin. So I would recommend with the evidences that first the standard was cisplatin 5-FU that was proven by the Japanese trials. Next, you can substitute the 5-FU with the capecitabine, so it will be cisplatin and capecitabine oral. The second option could be DCF regime that has been proven by the recent trial from the Japan, Jacob trial. So I think we can stick to that trial. Third one, what is being practiced in India, Tata Neuro Hospital, they have got a good number of patients with good results with the neoadjuvant chemo, only with the regime of paclitaxel carboplatin. That's the one thing. The next thing, you said that he had the history of thromboembolism, the limb ischemia. So I think that was a risk factor for the development of the anastomotic dehiscence as well. Because last time when somebody, I've noticed somebody or yourself, described what are the risk factors for the anastomotic dehiscence. In the next, one of the risk factors was the thromboembolism, hypertension, atherosclerosis of the artery. So that could be a contributing factor for the anastomotic bleeding. Next, you did not mention, was this the R0 resection intraoperatively or not?
Intraoperatively, it was an R0 resection.
R0 resection intraoperatively, because I don't remember. So it was intraoperative R0 resection. Then the final biopsy report says the radial margin was less than 1 mm. So what do you Sandeep think? Radial margin of less than 1 mm. Is it okay? It should be considered R0 resection. It should be considered R1 resection, R2. What should be? So you should think like a certain margin R plus R1 resection, because it is said that nothing has been very properly studied, but the guidelines say more than 1 mm radial margin is negative. Less than 1 mm margin should be considered good. So it's one factor, the radial margin was less than 1 mm. You can go to the CT scan film, which showed that there is the the adherence to the left main bronchus, and intraoperatively it was defined because the adherence to the left main bronchus as well. The next one, the operative intraoperative time was quite long, 8 hours. That could have also led to the anastomosis. There are several factors. Definitely the blood loss would have been there. Now the next thing is, he developed the anastomotic dehiscence. In this bulky disease, we have the option, because we think the intraoperative patient might require post-operative radiation therapy because he has not received radiation therapy in the beginning, or you have got the R plus macroscopically margin during surgery. So what would be your choice to take the conduit through the retrosternum or through the bed of the esophagus, transmediastinum? Our routine practice is to pull up the stomach through the bed of the esophagus, perform the esophagus removal. In this case also, the esophagus was kept in the bed of the previous esophagus. So I think that is not a good idea. We should reconsider now. In such suspected cases, we think that there could be the R plus resection, or even the patient requires post-operative radiation therapy. Then it's better to keep the in the retrosternum, so that if the radiation has to be given, it will not go directly to the stomach. it will go to the tracheobronchial tree or nodal disease where the radiation has to be taken. So we have the two improvement that should be done. We can learn from our case that first, the chemotherapy regime maybe was not appropriate. The second, that the stomach should have been pulled up in the retrosternal way, just retrosterally. The next thing, you said after, now is 9 months after surgery, right? Maybe 12 months after the initiation of chemotherapy. It's already 1 year if you take the follow-up completely. Now he has got the stricture at the pulled up, the esophagus, the anastomotic region. The scope could not be negotiated, speed board. So there's no option to dilate it. And he has got now the fistulous communication of both bronchial tree to the stomach, right? So how will you do now next? What would have caused this fistulous thing?
I think in the post-operative period, there was a growth in the left main bronchus when we did the bronchoscopy in the post-operative period. I think because of the recurrence, it was planned for radiation therapy. And this adjuvant radiation therapy might have also precipitated the.
So first thing that he has got the CT scan shows that he has the local recurrent nodal disease in the nodal burden in the subcarinary region also characterized. So there is the history, and the stomach has to do the muscle. So what we should think, the radiation therapy has been, sometimes radiation therapy can cause the erosion also in the stomach. So tumor might have got by his surgery. So therefore, now the fistula tract is going to develop between the left main bronchus and the right, right? Another thing is then there is a thoracogastric anastomosis in the neck that is stenosed. We don't have access to this, right? So the only option, the question will be how we will manage the patient. We cannot use the GI tract per post or per nose to go to this conduit level, right? Because it's stenosed. Right? So now the first question would be that can we give the radiation therapy to this region? But why? First, because radiation therapy was used already, but it was only 20 grades, right? So we have it in our hands. We can give up to 50 or even 60 grades of radiation therapy in total. So we can give more radiation therapy, but will it be beneficial? Is it justified or not? What would be the reason for that?
The RT might increase the size of the fistula.
Very good. So one thing that in a context of any GI tract and tracheobronchial fistula, RT is contraindicated. It will rather increase the size of the fistula. So therefore, RT doesn't have any role. Second comes the chemotherapy. Here, set the chemotherapy cells because it was ineffective. We can attempt for more chemotherapy. That's not going to help in this particular patient. But for just to prolong the life, we can use some changed version of chemotherapy, the signal line chemotherapy. So we have, but that will not cause any change. That will not make the fistula heal because this is the malignant fistula. One, it would have been the benign fistula is different. Since we have your bronchoscopy which was done today, also shows there's the malignant infiltration of the both bronchial tree. In the picture, I could see that the infiltrating region in the both bronchial tree, and you could introduce through the fistula into the stomach. It's confirmed. You don't need anything extra. That's the main confirmation that he has got the fistula with the gastric conduit, right? So chemotherapy can be given, but with a questionable effect. That's not going to do anything with the fistula tract, right? The third thing is the immunotherapy. Yes, we can give the immunotherapy. That will make the amount of the tumor shrink, but that will not also cure the patient. So immunotherapy also can be given for the tumor, but not for the fistula, right? So whatever we do is not going to change the quality of life of the patient because he's doing the fistula, he has got the aspiration of the stomach content. The only thing that he's living because he has got the feeling too, and he's not eating anything per month. So therefore, he has not got the component of aspiration from the mouth, but he has got the component of reflux from the stomach that's going inside the tracheobronchial tree. So therefore, he requires the treatment, right? So now the next option that he very well said summarized that we have only option of the stent. The few things that I would like to ask is, he said that we have got two kinds of stent, right? One is the expandable metallic stent, and then another was the plastic stent or silicone stent, right? The first question comes in any case of the malignant fistula, case of malignant fistula. Conservative, I don't think the conservative treatment will be successful in this case, so there's no hope for conservative treatment. So the question comes first, which stent would you prefer? In this particular patient, can we stent the GI tract? No, because we don't have the access. If we had the access on the GI tract, for example, there is the fistula with the anastomosis candidated, then yes, we could have that. So let's take first scenario that we can access to the GI tract. There is a tiny somewhere fistula here, but through the anastoma we can introduce inside the gastric factory. Then what we have the option of both stents. So which stent will you prefer? SEMS or the silicone stent? The first thing we should know, the silicone stent is used not in the GI tract, it is used for the tracheotomy. So now the next question will come, what you would like to stent? Would you like to stent the GI tract or would you like to stent the tracheotomy? What would be your answer?
The tracheotomy.
Why?
Because
not in this patient, not in our patient. In a patient with GI tract is accessible. Why the tracheotomy, not the GI tract? If you are stenting the tracheotomy, again there will be the minor opening, again there will be the secret spirit leakage from the esophagus into the tracheotomy. So why you consider the tracheotomy stenting? That's also one of the answers. But if
the stent migration will be more in the GI tract as compared to the stent migration.
Yeah.
And because it is not a native esophagus, in this case it would be in a.
But he has got the. You were talking in the context of recurrent tumor. So if there is the recurrent tumor, there is the capacity of the stent less likely to be migrated. Definitely, if there is no tumor growth, only the esophagus is there and the lesion is, the stomach is there, you cannot stent it because if the anastoma is located in the neck, this is one of the contraindications for the stenting. The second, there will be no holding power, right? If I were losing my esophagectomy, yes, you can do, but again, it will not hold. Right? But there is the options. They were saying the tumor growth, malignant fistula says there is the option that you can stent the GI tract. So therefore, the answer would be, it depends upon the situation. The certain criteria is silicone stent. Have you heard about the silicone stent? He said he showed a very beautiful picture. So stent silicone stents are not used for GI tract. Usually in the past, very initially, when the stents were developed, they didn't have the self-metallic stent. They used to use the plastic stent for the esophageal insertion also. But nowadays they are absolutely don't use it. So for the tracheobronchial, he said there is an introducer specific. It has to be done only by the rigid bronchoscopy. We cannot do by the flexible bronchoscopy. The rigid bronchoscopy is used. This stent, it looks bigger. It has got words to hold inside the tract. So that will hold that micro. Then there is the box-like introducer and the folding device with the fold into the fold. And the rigid bronchoscope is introduced. Through the rigid bronchoscope, you now push the stent. You can very easily access the stent, silicone stent inside the tract. It could be the straight stent that one of the pictures here showed. It could be a wide type stent, for example, you want to introduce into both bronchoscopy. So it will be like this, particularly like in the picture of the tracheobronchial configuration. So this is the wide type stent or the straight stent. So the big advantage of this stent is that you can retrieve very easily. For some reason, let's suppose the fistula is here with the benign condition. Even in malignant condition, we are stented, we are advised to the radiation therapy, and now the tumor is gone, the help of the radiation therapy. Then there is no necessity of putting the stent, right? So you can remove it. So if you have inserted the SEMS stent, it's very difficult to remove the retrieve back the stent. So that is possible in the context of silicone. This is one advantage to introduce the silicone stent. The very good author in the asked the exam is called Truman. He was a French physician, was a pulmonologist from France. He discovered the silicone stent and he died in 2020. So till his death, he was very much popularizing this stent. Though in the rest of the world, people were using the SEMS. He was the only guy that he said that silicone stent is better. than the SEMS. The advantage of SEMS stents is that you don't need to use the rigid bronchoscope. You can use the flexible bronchoscope. You have the option using rigid. For the rigid, you have to take the patient in theater. For flexible, you don't need. The option is like in the esophageal stenting. What we do, we insert the bronchoscope, flexible. So this is the trachea, right? This is the bronchus. So we can introduce the flexible bronchoscope. Here is the tumor growth in the fistula of the esophagus somewhere. You may pass beneath, or may not be possible to pass inside. Then you pass the guide wire, right? Remove the bronchoscope. With the guide wire, you can put the marker, like we do the metallic marker in the C-arm fluoroscope. Then after that, over the guide wire, push the stent. So the stent is over the guide wire like this. We push the stent. Now you reinsert the bronchoscope flexible above the marker, and then you can underpiece and you can deploy the stent. So the stent that we use for this purpose, we have the option of uncovered stent, no use. Never use the uncovered stent because this is not going to fulfill the purpose. So what we use, we have the option of semi-covered, partially covered, or fully covered. Fully covered, again, we don't use it because it's for the manual fistula. Perhaps the patient will live with the stent inside it. So therefore, we always use the semi-covered, not the fully covered with migrate. So the semi-covered stent is the answer. Now, the next question comes, as we selected whatever, the first priority should be given for the SEMS, right? The next question comes, which tract? GI tract, tracheobronchial tube, or both? The answer would be that let's suppose the situation.
Whichever is approachable should be first, right, sir? Whichever is approachable. GI tract
Like in our
approachable.
case, let's suppose another scenario. We can approach to the GI tract also. There is the fistula, but the anastomose is patterned or dilated the anastomose. Now we have access to the GI tract. Also, we have access to the trachea also. Which would stand first? GI tract. The one, because it is simpler, you can access to the GI tract. But there are situations. Take first situation. If the diameter of fistula is too big, too large, if more than 2 centimeters, what will happen? If you go through the GI tract, then there is a chance that that will migrate into the fistula if you go into the trachea. So this is one scenario where the GI tract is not stented first. Or if you need to stent, you have to stent the tracheobronchial tree as well, double stent. The second scenario, if the patient has the component of tracheal invasion or bronchial invasion causing the stenosis. Once you put the SEMS inside the esophagus due to the radial force, the stricture or the stenosis of the tracheobronchial tree increases. There is the component of dyspnea because of this growth inside the trachea, let's suppose. Now esophageal stent is kept. It will expand. Right? Now it will compress more the trachea. The degree of airway narrowing will be more. So therefore, in such scenario where there is a component of tracheobronchial stricture because of the tumor, then you have to stent first the trachea rather than the GI tract. This is the next scenario where that's now either to use 2 stents or say 1 stent. Always 1 stent is simpler. But in the situations where you cannot control larger fistula, as I said, or where is the component of both the tracheal stenosis and the GI tract fistula, then you have to use the 2 stents. So these are the scenarios that we can have. Now coming to our patient. This was just theoretical discussion. To our patient, he doesn't have access to the conduit, right? Because he has the stenosis here. Sir, what is that? He has the stenosis here. Now we have the only option of accessing to the trachea. So the only answer would be that we can use the 2 stents, put 1 stent, wide stent, like this one. So that may close the fistulous opening. Now what next? Nothing. We don't have any options. So we can try, perhaps we can talk to the patient party. We have to also look for whether it's available in Nepal also or not. How much does it cost? Because when last time, 5 or 6 years ago, I had asked what was the cost of this tracheobronchial stent, it was about 2 lakhs each. Quite expensive. So this depends upon the quality. Just will improve the quality of life, will not cure the patient. If the life expectancy of the patient is more than 3 months, then we can go for the stenting. If it's less than 3 months, maybe there is no benefit. So our patient, we cannot do much, but we can attempt for the tracheal stenting. एनिथिङ एल्स तपाईँले के भन्नु छ भने कि
गरे पनि त सर उसले मुखबाट खान सक्दैन प्यालेटिभ
मुखबाट खान सक्छ
ड्रुलिङले मात्र
मुखबाट खान सक्छ
Only pneumonia प्रिभेन्ट गर्नु
रिकरेन्ट इन्फेक्सनलाई प्रिभेन्ट गर्छ